Welcome to What Your GP Doesn't Tell You, the podcast for both doctors and patients with me, Liz Tucker. This week, I'm talking to NHS cardiologist Dr Scott Murray, who discusses what we can all do to reduce our risk of heart disease. I think we're probably familiar with the idea that elevated levels of the so-called bad cholesterol, low-density lipoprotein, or LDL for short, have been linked to cardiovascular illness. But Scott argues the picture is actually far more complicated than that, and we need to be looking at all the different elements that make up our cholesterol and fats. So that means looking at our figures for total cholesterol, high-density lipoprotein, or HDL, the previously mentioned LDL, and triglycerides. And there is one other factor that's often overlooked, but that Scott believes is an even bigger risk than cholesterol, and that's having a high blood sugar level. But the good news is there is preventative action you can take. But before we get to the details of Scott's interview, a brief request from me. If you enjoy this podcast and would like to leave a review on Spotify or Apple, that would be much appreciated. It really helps. You can also become a paid supporter of the podcast at patreon.com/whatyourgpdoesn'ttellyu or via PayPal on my website, whatyourgpdoesn'ttellyu.com. A huge amount of work goes into both the research and production of this podcast. So even a small amount of money makes a huge difference. And you can find out more information about the pod on my website, where you can sign up for the podcast mailing list, follow me on Twitter at Liz C. Tucker, and on my Substack account, liz.tucker.substack.com. Many thanks. And now back to Scott's interview. Dr. Scott Murray is an NHS cardiologist based at the Wirral University Teaching Hospital. He's also the founder and medical director of Ventura Cardiology, a heart health clinic. He has a specialist interest in preventative cardiology and is a previous president of the British Association for Cardiovascular Prevention and Rehabilitation. Here's Scott's interview. Hi, Scott. Many thanks for joining the podcast today.
Absolute pleasure, Liz. Thanks for having me on.
Now, Scott, one interventional technique that used to be used much more in cardiology than it is today is something known as stenting, which is used to expand arteries that have become narrowed. So why is it not as popular as it used to be?
Yeah, so it's a bit nuanced. If you're having a heart attack, then you need a stent, basically.
Of course.
There are two types of heart attack. There's you need to go to the cath lab, like right now, when the artery is completely blocked. And then there's one where you really need to be there somewhere between 24 and 72 hours. That's when the artery is partially blocked. In those circumstances, what you need is an interventional procedure, and you need it done well and the stent well expanded and imaged, etc. Where there's been conflict over the years is whether putting stents into patients who are stable and get predictable typical angina because of a narrowed artery, whether those patients really need a stent or not. And again, that's nuanced. One of the things that put me away from stenting, my MD thesis was in intravascular ultrasound. So we were putting an ultrasound catheter into the arteries that were partially blocked of these patients. And what you find when you start to look deeper is that there's not just one spot, it's the entire artery that's diseased. And yes, there will be areas around where the artery splits or bifurcates that are worse than others. But you're basically putting a stent into what is an inflammatory disorder. Like whack-a-mole, you put a stent here and you whack that bit, and then the patient comes back about 3 years later and the end of the stent looks a bit rough, so you put a stent there and then might fur up, so you put another stent inside a stent.
So where would you stop, basically?
Yes, I mean, you can't stent the whole artery, although that has been done. It's actually got a term, it's called a full metal jacket, where you put stents all the way through the artery.
And of course, presumably it might not just be one artery anyway.
No, there are 3 main heart arteries and the branches. And back in the day when interventional cardiology was in its infancy and we realised we could do these techniques, it was very much a back-patting exercise where it was, you know, guys, look what I've done. I've managed to do these stents here. But the question is, do they live longer? Do they live a better quality of life? And what's the balance of risk between maybe just giving them better preventive advice earlier in the pathway so that they don't get to that point versus a stent? Just because we can doesn't mean we should. And let's face it, a lot of these devices and drugs have been sponsored by the medical pharma industrial complex that writes the guidelines in essence.
What are the results then for stenting? Clearly, as you say, if you've got full blockage and you're about to die, then obviously that makes sense. But for patients with less severe heart disease, how much do we know about actually how effective this approach is?
Well, there's only really one decent sham trial in both sides of the study. They think they're getting a stent, but one half go through the entire procedure, but a stent is not inserted. And that trial was called Orbita. And I think Orbita 2 is actually going on to try and refine what they found in that. But they found that although there was a symptomatic initial benefit that was possibly greater in the stent arm, that in the longer term, patients didn't live longer or live free from heart attacks any more than they did without the stent. Maybe about 10 years ago, there was a trial called Courage, which was a big trial that came out of the US and other centres, showing that in the long term, there is no difference between medical therapy and stents for stable angina. There is a caveat. So there's been a trial called Ischemia recently, and what they found was that even if you've got a reduction in blood supply to your heart muscle from a narrowing, as long as that narrowing is not critical and is not in a critical position in the artery, i.e. the left main stem or the ostial or proximal left anterior descending, that's the main artery down the front of the heart that supplies the front wall of the heart muscle. You know, if you've got a narrowing that is causing a lack of blood supply in that artery or in the main stem, then those are the people we need to weed out, in essence, for further testing and possibly stenting. If it's anywhere else, you can get away with just medical treatment and the right advice. The problem now is getting people the right advice when there's so much conflicting evidence out there and all of social media and YouTube and everything telling people, you know, to lick some cucumber and their arteries will be cleared or whatever, you know, the nonsense.
But Scott, is there not also sometimes a problem with some of the messaging from the public health authorities? I mean, you've mentioned in the past an ad campaign that didn't quite work because it showed a man with a tight belt around his chest, which was supposed to highlight what chest pain might feel like, but in fact was misinterpreted by some patients.
Yeah, so there's the famous story of someone turning up in A&E with a belt around their chest, saying, I've tried the belt for the chest pain, it still isn't working. It just boils down to that messaging. We tend to overcomplicate things.
Sure. Now, if prevention is key in cardiology, it's going to be much harder, isn't it, to get funding for those trials? Because I can't imagine if you're a manufacturer of medical devices or drugs, there's a particular financial interest in running those.
No, that's why prevention doesn't get any funding and has never had any real major funding. It's very, very difficult because, let's face it, the NHS always will be, I suspect, a sick care service, not a health service.
And presumably having to make incredibly difficult decisions about who you treat.
Well, yeah, I mean, to some extent, the difficulties in that got worse after COVID to some extent, I think, because we're dealing with people, they're coming later in the disease state because they've had 2 years with no healthcare in essence. You just wish sometimes you could say, if I'd seen you 3 or 4 years ago, I may have been able to offer something that would change your course. But now you're on a path, it's going to be very difficult to get you off that.
So what sort of things are you seeing, Scott?
We used to see patients who had 1 or 2 things going on, but now the list of ailments is 5 or 6 deep in most patients. So it classically starts with pre-diabetes or diabetes, then you've got metabolic syndrome on top, then you might have arthritis, you might have a previous stroke, you've got fatty liver disease, you've got renal impairment because of all of that going on, high blood pressure, cholesterol abnormalities. So it's an exceptionally difficult situation to roll back those years. And if we could get people at the pre-diabetic stage and said, look, if you correct this, then we'll probably correct your lipids, your blood pressure, we'll probably correct the chances of getting fatty liver disease, high blood pressure, which lead to kidney failure, vascular disease, stroke, a singular point of failure in many patients, which is lifestyle, sleep, exercise, diet, stress, you know, the habits that they've carried on. That's often the single point of failure that happened 30 years ago.
I think one of the surprises to a lot of people when they look at preventing heart disease is that blood sugar seems to play a critical role, and that doesn't seem to get highlighted in the same way as cholesterol.
Yeah, I would argue that it's more important, and probably because your blood sugar is going up and down and your body's having to deal with that constant daily tirade, is that you will develop raised cholesterol as well. If the stuff you're taking into your body is ultimately making you energy toxic, you'll become both glucotoxic and lipotoxic, which means that your blood sugar struggles to control and you struggle to control your blood lipids and your lipoproteins. And it's probably those two things that are changing the way that your blood vessels respond. On top of that, high blood pressure, endothelial dysfunction, which we can go into. Those are the things that are causing heart disease. And that's why heart disease is up to sort of 80 to 90% preventable. If you get someone early enough, give them the right advice so that they don't do the wrong things in terms of their metabolism, then the hope is that you would stop that cascade of events.
But do you think GPs look enough at blood sugar levels? And I don't mean once people get to the pre-diabetic range, because you're not suddenly not pre-diabetic one day and pre-diabetic the next.
Yeah.
When people start heading towards those pre-diabetic levels, that's the time to take action, when your body still probably has more flexibility too.
Yeah. It's because in a medical sort of guideline-based paradigm, we've sort of moved things into the black and the white. Oh, we'll measure HbA1c, which is your blood sugar on your red blood cells, over 3 months. And what we'll do is we'll look at a cut-off for that. Then we say, oh, it's okay, you're 43 on your HbA1c, so you're not diabetic, but you're pre-diabetic. And I absolutely hate that term because it gives patients, oh, I'm all right, I'm just pre-diabetic. You know, the doctors told me not to worry, just need to make some changes. And they don't. They'll still go on eating the same foods and they will ultimately become diabetic. They are diabetic is what I would say. I just say it's a spectrum, and right at this moment, your needle is going the wrong way and you need to start scaling back on things that are putting your blood sugar up, that are energy dense as well. Because let's remember, it's not just the blood sugar at that moment in time, all the energy you've got stored on your body. You can put your fasting blood sugar up just by getting fatter and having more long-term stores. And we don't let patients know that if you just decrease how fat you are, both viscerally and under your skin, your fasting blood sugar will go down.
So what's happening to our hearts when our blood sugar goes up?
Your arteries are lined by something called endothelium. If you think of that like the wallpaper on the inside of all your arteries, and that wallpaper is a living, breathing organism, and it basically controls whether your arteries are going to be healthy or not. Now, what it has in order to keep that health is on top of it, it's got a sort of layer called the glycocalyx, but it's a layer a bit like fish skin.
So it's a lining, basically.
Yeah, it's a lining. It's got tiny little hairs on it that are basically responding to how the blood pressure flows over them and whether that flow is laminar and whether it's at the right pressure. And that's what keeps those cells happy, along with a gas called nitric oxide that the cells can make. Now, they will make that if they're happy and they will stay happy. But if you flood the bloodstream with high sugar and high lipids, then you will denude or you will wear away the glycocalyx, that protective layer that's above the endothelial cell. Blood should flow over that very slickly, like imagine a maglev train that's running on magnets that just flows and the cells are happy, everything's fine. If you get rid of that with a high sugar diet and high lipids in the blood and your blood pressure's high, you basically expose the endothelial cell and the endothelial cell is unhappy and it might start to let lipoproteins in between the endothelium. And then is when you get the problem, because that's you getting a little bleb under the wallpaper. And when you get that little bleb, the body signals that there's something not right. It can activate the immune system to come in and start to try and deal with that. And when it deals with it, that's when the wheels come off. find ways to keep your endothelium happy and recognize when your endothelium is unhappy. And what I'd say is, for a man, one of the first things that happens if you've got endothelial dysfunction is you can't maintain an erection. You get erectile dysfunction. So if there's any men listening in their 40s or 50s who've got erectile dysfunction, go and see your GP, get your blood pressure tested, get your blood sugar tested, get your blood lipids tested, and start looking at maybe why you're not keeping your endothelium happy.
The high sugar is causing an inflammatory response.
In essence, yeah, because your glycocalyx needs a very stable environment, and your endothelial cell wants a stable environment. It's called homeostasis. It just wants everything to be right. Blood pressure to be right, blood sugar to be right, blood lipids to be right, laminar flow wafting down the little hairs or brushing the hairs. And when it doesn't get that, that's when things go wrong. Invest in your arteries. Don't start saving for your arteries in retirement, because you need to start investing in the 20s. Seeing people in their 30s with vascular disease, late 30s, early 40s. We need to start educating kids and teens and 20-somethings that you aren't going to live forever.
Well, let's look at cholesterol and lipids in a bit more detail if we can. The conventional view is to reduce cardiovascular risk, we want to reduce low-density lipoproteins, or LDL for short. But you argue that we need to be looking at all the lipids, not just LDL. So if I get a blood test done, I'll get a figure for HDL, my high-density lipoproteins, LDL, my low-density lipoproteins, my triglycerides, and also my total cholesterol. So how do all these figures give us information about heart disease risk?
Yeah, so we shouldn't necessarily be talking about cholesterol. We should be talking about the lipoprotein that carries the cholesterol. Cholesterol can't be in the blood on its own, and it's wrapped up in this lipoprotein. Now, what I would say to simplify things is HDL cholesterol is so complicated that not even top lipidologists in the world really understand it. And how I've explained it recently is probably a platform for various proteins, cholesterol, triglyceride to jump on and off, as well as oxidated phospholipids and all sorts of things, to jump on and off in order to be involved in reverse cholesterol transport, which is a really important thing.
And reverse cholesterol transport means?
Bringing cholesterol from tissues where it's either oversubscribed or in the wrong place and bringing it back to the liver to be repurposed. And that's a really important thing for people to have. We've basically evolved this so that we can repurpose our cholesterol, not have it hanging around. The thing that we have done, which I think is wrong in the UK, is that on a lipid panel, we've said, oh, let's just do it non-fasted now. Just come anytime and get your lipids done, and we'll focus on non-HDL cholesterol, so your total cholesterol minus your HDL. And the reason that we've done that, I think it was well-meaning. I don't think it was in any way contrived, but that's a surrogate for something called your total ApoB. Now, ApoB is a signature that is contained on all of the lipoproteins that are potentially harmful. Think of ApoB as being bad. And that is present on VLDL, which is what the liver releases first with cholesterol on it. It's present on LDL. It's present on another atherogenic particle called Lp(a). And therefore, the totality of those particles, I think in the future will be something that we'll measure through an ApoB measurement, which is much more accurate probably than measuring LDL cholesterol in terms of your overall risk, because there's discordance between those measurements. And what I think GPs should be doing, and what we should go back to, is asking patients to come for their lipid test fasted, and particularly looking then at the triglyceride. Because if your triglyceride levels are high fasted, it means there's a metabolic problem.
And some people have suggested that actually it's the triglyceride HDL ratio that may be more useful.
Yeah, so that does have a correlative ability with insulin resistance. And it is a marker that you may be suffering from lipoprotein insulin resistance. If insulin is high, it basically tells the liver to make more lipoproteins. So it's the exact opposite of a statin drug. And that is why we want people to live their lives so that they sensitize their body to insulin with exercise and with weight training where they can. Don't eat as energy dense meals that is going to raise insulin and put the body on store mode, and maybe spend a bit more time fasting. But you still need insulin within its dynamic range, because it also does good things, insulin. Insulin gets bad rap, but it's only bad rap if you're making it 4 or 5 times what you need it, and that your body's becoming deaf, dumb and blind to insulin because of that. What you want is you want your triglycerides to be less than 1 fasted, and you want your HDL to be greater than 1 fasted. If you can, that's a healthy profile. But I see people with an HDL of 0.5 and a triglycerides of 4. So 4 over 0.5 is 8. You know, a serious difference in those metrics. The other thing you can do is you can work out remnant cholesterol. You take your total cholesterol, you subtract your LDL, and you subtract your HDL. It has to be fasted though. What's left over is your remnant cholesterol. And if it's less than 0.5, you're in pretty good nick. I don't worry about people who've got remnant cholesterols of less than 0.5.
But I think there's huge confusion, because I hear from a lot of listeners that basically if they go into the GP and their LDL is above a certain level, that's the indication that the GP looks at.
Yeah, we're still probably in lipidology and in guidelines in GP land. We're maybe, I think, 10 or 15 years off the pace. I'm not blaming GPs for that. They've got the hardest job in medicine, because you basically have to be a jack of all trades and a master of none and deal with everything. Context matters. If you're a skinny, exercising, ice bathing keto warrior who's like very thin, who exercises every day and fasts intermittently for 12, 15, 18 hours at a time, and your triglycerides are exceptionally low, your HDL's in a reasonable position, and your LDL's gone up a little bit, you're probably not at as much risk as someone who is exceptionally overweight, has reached a personal fat threshold and has high triglycerides and has high LDL as well. So in the early statin trials in Scotland and WASCOPs, etc., all of those people who were in that trial were essentially diabetic when you look at the markers. We're dealing with an overweight West of Scotland population. They were helped by cutting down the number of lipoproteins they were sending out using a statin drug. Context matters.
So, for example, someone like me who's had their lipids tested in a fasted state, I do have a slightly raised LDL, but my HDL is in a healthy range. My triglyceride level is actually low. So might it be for me that my raised LDL level may be less of an issue than it is for some people?
Yeah, that's one of my issues, is that GPs are not paying attention to the triglyceride. Triglycerides themselves are not causal in terms of causing the disease, but they're a very good proxy for you being metabolically disturbed. Probably in your case, what's happening is you're shuttling around a lot more cholesterol within your LDL particle, because your LDL particles are probably big and fluffy and buoyant. If you use the analogy of the difference between ping pong balls and balloons on a thick grass, tip out a big box of ping pong balls, and those are small, dense LDL particles that get trapped in the grass. Those are more likely to cause the endothelial issue and problem with retention and the immune activation. Whereas if you've got big bouncing happy balloons that just bob along the glycocalyx and don't get trapped into the endothelial subspace, then that's probably a healthier thing. And as long as you don't know these things, but you can only hope that you've got good endothelial repair, you've got a healthy glycocalyx, you've got good nitric oxide, your vessels are happy and your microvessels are happy, then there's many of us who think that your LDL doesn't matter in that situation because it's never going to get trapped.
So in the end, if your LDL level is high, what determines whether you need to take action?
The scoreboard should be whether you've got coronary artery disease or not. And that's one of the reasons why we created Venturi Clinic, was we wanted our own CT scanner so that we could put people through there to adjudicate whether they should be aggressively lowering all of their risk factors or not. And I now have patients in their late 50s and 60s who've got a cholesterol of 20 with an LDL of 13.5 who have normal coronary arteries and no disease.
Yeah.
And I have not given them statin pills because they're just protected in some way. There are people who are protected from getting heart disease.
My total cholesterol level is 7, so a lot lower than that, but certainly a figure that would be seen as higher than ideal by some people.
In the early days, going way back, when we measured the population, the average cholesterol is what you can measure in a bell distribution. And that's how they come up with normal. It's not normal. It's just that this is the average for a population. And there will be some people who are up the 95% tail. And previously it used to be the cutoff for a worrying cholesterol level was 7.5. But then over the years, that drifted down with all of the statin trials, down to lower is better and treating to target and all those things. We got down to a situation where it was 4 and 2 for a while. And now it's an LDL of less than 1.8 if you've got existing coronary artery disease. And the GPs get paid and have registers run by the GP practice managers in order to pick up patients who should be on statins that are not, because they get paid through the quality outcome.
Or who they believe should be on statins.
Should be on, yeah. Because that is felt to be by NICE and by other health bodies that's an important target to treat. Now, I've seen people on statins with perfect cholesterols whose fasting triglycerides are 4.5 and their HDL is less than 1 and they've had a heart attack on a statin. So it is nuanced.
And you'll be aware that there's a group of scientists who argue that there isn't a link between cholesterol and heart disease.
Yeah, I know of them. I can see why they've got that message interpreting some of the stuff, the studies they've interpreted. But what I would say back is that lipoprotein metabolism and the cholesterol levels are basically a proxy for how healthy you are. And if we get it right, we would be able to target people earlier and we would be able to decide on what is the best course of action for them. And that doesn't always mean a statin drug. I think that we should reserve those things for people who cannot embrace lifestyle and prevention, because there's so much more benefit to be gained by exercising regularly, getting on the right diet and sleeping well and de-stressing. So, I'm not poo-pooing their argument, but I think we're not just going to start ignoring LDL-C levels and HDL-C levels and lipoprotein metrics. If anything, I think we should be delving deeper into those so that we can understand the mechanisms. So looking at total ApoB and LDL particle count rather than LDL cholesterol content. And we should also be looking at lipoprotein little a, which normally if someone has a family history of heart disease and people have heart attacks in their 40s and 50s, it's an insanely high level of lipoprotein little a that's driving that.
So your argument is lipids are important, but it's oversimplistic just to start looking at LDL. We need to have a much more nuanced conversation.
Absolutely.
About all the lipids and the different things that make up those lipids.
Yeah, and I think it's just coming round now that we're actually starting to look at the spread of particular sort of lipoprotein abnormalities that we see in different patients. If your triglycerides high and your LDL is rising, there's a serious problem.
Now, we mentioned statins, and interestingly, quite recently, NICE brought in additional lowering again for statin recommendations. Yet, most of the statin data was in by 2013. So the same data was there. So what drove the requirement that said you can take a statin at a lower level of cholesterol now?
I think there's basically summed up by the cholesterol treatment trialists who are out of Oxford. They were run by a chap called Professor Rory Collins. He might be a sir now.
He is, I think, yeah.
Basically, what they did was they got a whole load of money from various pharma companies, and all of the data on LDL lowering and drugs to lower LDL got put into a big statistical model and basically log transformed to produce a graph which shows that as you lower LDL cholesterol, you will get a defined reduction in cardiovascular endpoints. You can't knock that data because every trial that's been done that has lowered cholesterol metrics in LDL-C can fall on that line.
I suppose a criticism that somebody might make of the trialist is they've never opened up the data.
Absolutely, yeah.
Because of the industry agreement that they sign, the problem is all everyone can work on is the data that they've released, and they can reanalyze that data, but they can't get to the raw data. So some people might argue that's quite a big issue.
Oh yeah, I mean, I've been vocal about that in the past, that they shouldn't really have anything to hide. They should just release all the data, even in drugs that are not statin drugs. So PCSK9, ezetimibe, bempedoic acid, the outcome trials in those drugs that show significant lowering of cholesterol metrics fall on that line, or at least show an improvement in cardiovascular events for a reduction in those endpoints. So for me, what this boils down to is, again, that cholesterol, lipoproteins, however you want to package it up, is a proxy for the cardiovascular health of a patient to some extent.
But Scott, is it as straightforward as that? Because this remains, as you know, quite a sort of disputed area. One of the people I had on the podcast a while ago was Dr. John Abramson, who was one of the authors on several BMJ papers that reanalyzed the data from the trialist group, which, if you may recall, led to the BMJ having to hold an inquiry.
Yeah.
The BMJ inquiry found there were no grounds for retracting the Abramson paper, which had reanalyzed the statin data. And the only criticism they made of the Abramson paper was that there was a small misinterpretation of how another researcher had described the level of statin side effects.
Yeah.
The Abramson paper suggested that the benefits of statins had been somewhat overstated. And one of the complicating factors, I think, is how risk is often presented using relative rather than absolute risk.
Yeah.
For example, one of the figures was, just got it here actually, I think, was that for people with less than a 20% risk of heart disease, no impact on mortality, and doctors needed to treat 140 patients with a statin for 5 years to prevent one non-fatal heart attack or stroke. There was a recommendation, I think, from the trialist group that everybody over 70, for example, should take a statin. And the Abraham group found there was an even smaller benefit from that. So is it as straightforward? To me, as someone on the outside, it seems to me it's quite disputed. We can't get the raw data. And the BMJ papers, which I think were quite influential and important, suggest, say, for me, if I am low risk, and let's assume that I am for the purposes of this argument, 200 women in my group would have to take a statin for 5 years. So it seems to me, aside from what may or may not be the side effects, that's a separate issue, it actually seems quite disputed.
So we got a solution for that. And if you look at the Western Denmark registry data, this is why you can't just blanket bomb the population with statins, because the GP put it into a calculator and it spat out a percentage risk that was calculated from several studies into that area and is not in any way that person's exact risk. The scanner should be the scoreboard here. And the Western Denmark registry shows that if you've got a calcium score of 0 and an assumption of no severe prognostic coronary artery disease, then it's a waste of time taking a statin to basically alter your numbers. But if you've got calcium in your arteries, plaque in your arteries, your lipoproteins are abnormal, then as that calcium score increases and as the amount of plaque in your artery increases, then the benefit of taking drugs to lower your lipoprotein abnormalities are clear.
I'm just looking at figures for that, actually, from the study which the BMJ upheld. If statins are given to a high-risk group of men and women, 1 in 30 will not have a cardiovascular event, and 1 out of 80 will not have a cardiovascular death.
So this is where we should be focusing.
I'm not saying that's not a valuable reduction, Scott, but it's, I think, smaller than an impression that a lot of people get.
Yeah, that's because of the pharma playbook of using relative risk over absolute risk. But let's take an example of the PCSK9 trials. The PCSK9 trials showed that there was, particularly the Odyssey trial, after an acute coronary syndrome, that there was a benefit of reducing their lipoproteins down to an extremely low level after that event. Now, those trials were stopped early, and everyone thought, oh, well, they've been stopped early because of the pharma playbook and stuff. But cardiovascular disease is a very, very long process. And for those drugs in a double-blind, placebo-controlled trial to show a benefit within 2.5 years is actually pretty remarkable, I think. There is an element of pharma that we know has taken bad decisions in the past. The statin trials, where there was a run-in period of 4 to 6 weeks to weed out the people who obviously had side effects, which I think is often missed in this discussion. People do get side effects from these drugs. We can't overlook the pharmaceutical paradigm here, because there are patients who will never ever be able to embrace lifestyle or health literacy, and there therefore will be a treatment gap for those patients. So, I think it's difficult sometimes. We say that we should tell patients to do X, Y, and Z, but some patients just don't do it. What I think happens as well is that we slightly overdose people with statins. So it's a personal anecdote, but my dad has coronary artery disease, and when I found that he had that, I started him on a concoction of things. He went from having a total cholesterol of 7.6 with an HDL of 0.5 and triglycerides of 3 or whatever. He had fatty liver, etc. Typical Glaswegian man. But he took rosuvastatin 5 every day. And within 2 or 3 weeks, his total cholesterol was something like 2. And his LDL was like 1 point something. And he felt like his muscles were sore. And I said, look, you're obviously very sensitive to this. So he now takes rosuvastatin 5 3 times a week. He takes it Monday, Wednesday, Friday. And I have him on coenzyme Q10, which statins deplete and is very essential. And he's also on vitamin D, omega-3, vitamin K2. He's on a sort of concoction of things, and he is absolutely fine.
Is he an obedient patient?
Not when it comes to jammy Dodgers and malt whiskey. And he's been pulled off several times by me, but that was probably the root cause of his fatty liver and his coronary artery disease.
You see, one of the arguments Abrahamson makes, which I think is quite interesting, is that he believes that the harm in taking a statin is not the expense or possible exposure, perhaps, to potential side effects, but the false reassurance and protection that people may think it gives them from cardiovascular disease. Because whatever one's perspective on this, clearly the absolute risk reduction figures are smaller than certainly some people have believed. Put it like that.
What I would say, if you put those people in a CT scanner and you find that their calcium score is over 500 and that they've got multivessel plaque disease, then actually the number needed to treat to avoid an event with a statin is like 1 in 12. So this is my point, is that we should be focusing the medical treatments and tailoring it to individualized patients. And there's no way that someone who's healthy with a calcium score of 0 in their 50s, no matter what their cholesterol is, should be taking statins if they give them side effects. And that's where we've got it all wrong. The GPs are being reimbursed to give statins to people just because they hit 55 or 60. That is totally wrong. That's sloppy medicine. I don't think we should be doing that. But should we be targeting interventions to people who do have extensive coronary artery disease? I think we should. And I think the Western Denmark Registry gives us contemporary version of why that works. Who knows, it might be absolutely nothing to do with the cholesterol levels. It may be simply that when you deplete liver cholesterol and lipoprotein manufacture using a statin at relatively low doses, you actually regenerate the LDL receptor on the surface of the liver more ably. And that's how PCSK9 inhibitors work. They make your LDL receptors much more happy. LDL receptors are involved in a whole load of other things. The LDL receptor related protein is involved in the coagulation cascade. And maybe by making that system just slightly better, you make the blood thinner, you affect coagulation, which is a major part of why you would have a heart attack. This is like the film Inception. This could go down several further layers that we've got no idea about. And we're there just pontificating about the fact that someone's LDL went from 5 to 2.
So there's still much to be understood, really.
Yeah, the lipoprotein story is necessary for heart disease to develop, but it's one of the legs of a chair, and the other legs are inflammation, oxidation, and your immune response. And obviously, the chair itself is endothelial function, as we've gone into.
Earlier in our conversation, we discussed the links between obesity and heart disease. Now, in a talk you gave a while ago, it might sound a bit old school, but you suggested that actually prodding the patient to see what sort of fat they have could be a useful diagnostic tool.
That talk that I gave in 2018 for Public Health Collaboration is coming true. It was called The Heart of the Future, and it was about the rise of heart failure with preserved ejection fraction, which is a condition we are seeing more and more of as inpatients in hospital. We never used to see it, maybe because we weren't thinking about it, but we now know that that is a real worry for the future because of the diabesity epidemic. And what I was getting to in that situation is if your fat cells are full, then the fat on your body, be it your hips, your bum, your tummy, your chest wall, when you press it, it's quite tense because nobody knows what their personal fat threshold is really. But you could have a very good guess at it if your triglycerides are high fasting. That tells me that you're probably over your personal fat threshold. And if you are full to the brim of fat. Now, I can tell when I scan patients because I can measure their liver Hounsfield units and I can show that they've got fatty liver and I can see the enormous amount of fat that they've got around their heart. That's called epicardial adipose tissue or fatty heart. And we see this more and more in people who've got heart failure with preserved ejection fraction. Their heart is encased in a jacket of fat. Their heart muscle itself has fat within it, and that fat is starting to fibrose and to stiffen. And basically, their heart muscle struggles to relax. The relaxation of your heart muscle is the most energy-dependent part in the heart cycle. It's a bit like pulling back an elastic band. You need to invest ATP or energy in order for the heart to relax. And then when the heart pumps, it is a contractile process, but it's more of a recoil as well. And these patients pump well and their heart looks like it's pumping well, but it just doesn't relax well. And that has implications causing back pressure to the lungs because the lungs are trying to give blood into the heart and then it's filling back. It stretches the left atrium, the collecting chamber between the heart and the lungs, so people go into heart arrhythmias like atrial fibrillation, which further deteriorate their ability to fill their heart.
And the softer your fat, the better. Obviously not a great idea to have lots of fat.
No.
But soft fat better than hard fat.
Well, you think about someone who's had a gastric band and then they get all that sort of skin that's left hanging. That's just skin that used to be filled with fat cells.
Yeah.
And you probably see it yourself. I mean, I'm no angel. Probably by the end of a Friday when I've been good all week, I'll maybe look a bit trimmer and the fat in my love handles or whatever will be less tense. But then by the end of the weekend, when I've been enjoying myself, it might be a little bit more tense. If I would give anyone any ideas about that, it would be do something that empties your adipocytes, because that's the key. If you're exercising, you're fasting, you're eating low energy dense foods, you're eating maybe a bit more protein because the body has to invest energy to deal with that protein. There isn't really any new stuff in this game. It's diet and exercise and lifestyle and sleeping long enough, all the things that help you to empty your adipocytes. And if you're protecting your liver along with that and you're stimulating your mitochondria and type 2 muscle fibers by doing weights or resistance work, then you're starting to get more of the complete package about allowing your body to thrive. Doing the opposite of all that, filling your adipocytes, wrecking your liver, not sleeping well, eating energy-dense food is how you develop metabolic disease. So it stands to reason that you do the opposite.
I wear a Fitbit, and I really noticed the effect that if I've just been really busy and I haven't been doing just mild exercise of walking, when I go out again, my heart rate is slightly higher.
Yeah.
It happens within a few days.
Oh, it's constantly being micromanaged by your autonomic nervous system. If you lay down and basically, did box breathing for a minute, breathe in through your nose for like 4 or 5 seconds, then held your breath for 4 or 5, and then breathe out through your mouth for 4 or 5, and then hold your breath, you'll basically engage parasympathetic activity and overcome some of your sympathetic drive, and your heart rate will drop by 10 or 15 beats a minute, and your blood pressure will go down.
Now, you touched on diet as being a really important thing in terms of heart disease prevention. And I think there's huge confusion here because for a long time, people were told to eat low fat. Now there's a recognition that some fats are healthy and actually really important for us. So what advice would you give patients about what fats they should eat?
Well, I think we should just end the diet wars. We're all a bit tired of it now. When you drill down, everyone's kind of saying the same thing, but they just need to belong to a tribe. So what I tell my patients is, look, don't fear eating healthy fats. So what I would say is healthy fats is things that come in singular, natural instances, so non-processed foods. The fats that are in biscuits and buns and bagels and breads and anything that's got more than 4 or 5 ingredients, the sort of packaged foods that have got the sunflower oils and the rapeseed oils and all that stuff, the emulsifiers and the mono and diacetyl glycerols and all the sort of stuff that's basically like antifreeze. Bin all that. And if you're eating stuff your granny used to make, like a beef joint or eggs or fatty fish, extra virgin olive oil, a handful of nuts a day, avocados, all those things are fine. We shouldn't worry about those fats, even if you can tolerate it, dairy to a certain extent, because we know that not all fat is created equally, and there are some fats that are useful for diabetics. But what I would say as a caveat on fat is that it's hugely energy dense. And if you're already lipotoxic and energy toxic and you need to get weight off fast, then shoveling in a whole load of fat is not a great idea. If you've got fatty liver, there's already studies that show if you infuse a lipid into people, you can just go straight onto the liver. When you're already energy toxic, there's nowhere for it to go. So I think in those patients, they need to get to a diet that is calorie reduced. So you need to be under your calorie threshold by, say, 400 calories a day. And you need to be eating things that won't make you hungry. So avoiding high GI carbohydrates and getting your carbohydrates again from healthy sources such as fruits and vegetables, and trying to limit that to almost the smallest portion on your plate and make the protein slightly bigger and the healthy fat on the side.
And so would you rule out saturated fats, things like butter?
No, I don't see any problem with that. For people who are energy toxic, I don't think that's a great idea. I think they should be focusing on 1 or 2 meals a day that are nutritionally and nutrient complete so that you're getting as much as you can from your food. I think that we should stop the uber polarization of diet and all agree that we should be eating a balanced, healthy diet. And often that just means cutting out the crap, cutting out the things that we know are bad for us, but we're addicted to. So hyperpalatable, high fat, sugar and salt products. We should be cutting those out. The problem for us is that we're super addicted. Our nervous systems are hardwired to seek out those things because we used to worry that we would die in a famine, and we don't need that anymore.
So finally, Scott, I make you health czar for the UK.
Please don't.
What do you do?
Try and come up with something so simple that it's impossible not to do it. It is technically simple, diet and exercise, but diet has become so polarized. And over one end, we're hearing guys saying, just eat ribeyes and drink water, and that'll solve all your problems. And then on the other side, we've got vegan people saying it should all be plant-based diet. And then you've got some more people in the middle saying, oh, don't do that, do this. What happens there is the same as what happened in Russian politics. People are completely and utterly bewildered because one day on the front of the paper it says such and such, the next day it says the other. And people just give up. There's no point trying to understand it. I'm just going to do what I've always done, which is have biscuits with my coffee and have a bowl of cornflakes in the morning, and then I'll have pasta and a sauce from such and such at night. And then I'll just keep plodding along and I'll just steadily getting worse. And that's really sad. So whatever it was that came up with, it'd have to be something so simple and so easy to do.
So just eat whole food.
Yeah, eat things that are single ingredient, things that are known to be good for you with nutritional qualities, like fish and broccoli.
So not a packet of jammy Dodgers like your dad.
No, don't do what my dad did. But it's hard because it's expensive. Protein is expensive. We're now in a cost of living crisis post-COVID. It's just having that mindfulness that, one, you don't need a pudding after every meal. That's one of my bugbears. You don't really need to eat breakfast. You'd probably be as well just having a black coffee or a black tea and trying to get through that, because your body's then utilising some of the energy that you've got stored. And then if you eat something relatively healthy when you break that fast, eat some goddamn protein. Try and get through without dipping into that stuff that we know that makes us crave more. Because if you've got food addiction, one biscuit could just mean the whole packet's gone.
Clearly a difficult but really important problem to solve. So thank you, Scott, so much for talking today.
No problem. Thanks so much for inviting me, Liz. Bye.
Bye-bye. Hope you enjoyed the latest episode of the podcast. It will now be taking a short break, and we'll be back on the 2nd of November, 2024. And if you've enjoyed the podcast, if you could share it and leave a review on Spotify and Apple, I'd much appreciate it. It really helps. Many thanks for listening. Bye for now.